Now we move to next session from muscle to valve, imaging insight in structural heart disease. Our first speaker, Dr. Ahmed Musa, consultant radiology in Mediclinic. His subject, CMR diagnosis of arrhythmogenic cardiomyopathy, the Padua criteria.
Thank you, and I'm really pleased to be the non-cardiologist, the only non-cardiologist in the conference. So thank you. So just as a quick insight, the arrhythmogenic cardiomyopathy is a disease that was discovered in this late 70s, 80s. At that time, the scientists who discovered the disease thought this is a disease of the right ventricle, and it is probably related to the developmental nature of the right ventricle myocytes, where this allows early scarring and fibrofatty infiltration. Accordingly, in the mid-90s and in 2010, there were task force criteria that were proposed to diagnose the disease. And at that time, the disease was only thought to be a right heart disease. These are the 2010 criteria of the disease. And as you know, when you look to the right ventricle, you need to look to the wall of the right ventricle. You need to see akinesia, dyskinesia, or focal desynchronous contraction. And then you need to look to drop of the ejection fraction and dilatation of the ventricle. And then you decide that this is a major or minor. And then you start to look to the other criteria that you drive them from ECG, from arrhythmia, from family history and patient's history, and additionally from the structural changes. And at that time, the structural changes were driven from the endomyocardial biopsy only, and which is a quite limited procedure. It carries hazards, and also it has few problems. Among of the problems of the endocardial biopsy, that most of the people will target the septum, because this is the safest site for the biopsy. The disease itself is not a disease of the septum, it's a disease of the free and lateral walls. Additionally, the disease have a criteria of being a patchy disease that involve segments and leave segments. We call this a skip pattern of a disease, which is also against the accuracy of the biopsy. Now, if we look here to this case, here we can see an example of arrhythmogenic cardiomyopathy. If we look carefully to the right ventricle wall, you will see that there is a dyskinetic area of the ventricular free wall. This is happening together with a significantly dilated ventricle. In the presence of these changes in the right ventricle, you can establish one major criteria of ARVAC, arrhythmogenic right ventricular cardiomyopathy. Now, you need to collect the other criteria, as we said, from the family history, from the ECG findings, from the arrhythmia, until you decide that this is a disease happening in this patient. Here is another example of the case where if you look to the free wall of the right ventricle, you will notice what we call sacculation, or the accordion sign. This accordion sign means that there is lots of dyskinetic segments in the wall of the right ventricle. Together with this ventricle dilatation, it could present a minor criteria, because this patient actually is not having the so significant dilatation of the ventricle or the so massive reduction of the ejection fraction. So in spite of this, according to the old task force criteria, you may even neglect this feature and consider them absent in this patient because of the existence of wall motion criteria only, without a significant dilatation of the ventricle volume and without significant drop of the ejection fraction. Subsequently, we knew that there were some limitation of the old 2010 task force criteria. The first limitation was the quantitative values. The old task force criteria put a strict quantitative criteria that cannot be applied for everyone and will obviously reduce the sensitivity. Additionally, the old task force criteria did not put in consideration the evolution in genetic, and which took place between 2010 until now, where the scientists discovered that there are many genes responsible for the disease, and they are responsible mainly for the desmosomal function and integrity, which predispose for the disease occurrence. Finally, the old task force criteria also neglected the fact that the disease is not limited to the right ventricle. The disease actually can be limited to the left ventricle, and it can happen in both ventricles. Subsequently, there is a newly evolving category which is called ALVAC, which is arrhythmogenic left ventricular cardiomyopathy, and biventricular ACM, which is biventricular arrhythmogenic cardiomyopathy. These are the group of the genes that were discovered for mutagenic genes that are responsible for the mutation and occurrence of the disease in different subjects. These are the new criteria that were evolved in 2020 in the Padua University of Italy. They took it for a long time and they have studied the situation until they have came with the new classification that was implemented in 2020. Unluckily, because of the corona situation at that time, it was not so widely spread until the middle of the 2023. And we in Mediclinic Airport Road, we have adopted the new classification and the new diagnostic criteria in the middle of 2024. According to the new diagnostic criteria, the disease, as we can see, is classified into arrhythmogenic right ventricular cardiomyopathy and left ventricular cardiomyopathy. And you need to look to the major and minor criteria in the ventricles. We will discuss this as we go through the cases. The major differences between the Padua criteria and the task force criteria is, first of all, that while task force criteria proposed a fixed thresholds for the criteria, the Padua criteria were more flexible and they consider the normal nomograms for the subject. So you need to look to what is normal for the patient, a male and female, and also what about the body surface area. And if you are dealing with an athlete, then you need to consider the normal nomograms for each patient. The second thing is that a wall motion abnormality isolated in the old task force criteria without a significant dilatation or drop of ejection fraction was not considered a criteria. Now in the new task force criteria, it's considered as one minor criteria. If we go to the major criteria, the old task force criteria didn't consider structural criteria at all. They were relying on the endomyocardial biopsy. However, the new criteria relies totally on MRI for the detection of areas of fibrofatty infiltration. Going to the left ventricle, we don't have any minor criteria, but if you see a transmural late gadolinium enhancement isolatedly, that will be considered as one major criteria for left ventricular involvement. This is probably the most important slide in this lecture, which reflects what the pathway that you usually follow if you want to apply or you want to implement the Padua criteria for the arrhythmogenic cardiomyopathy disease. So the start of the diagnosis or analysis, you need to ask yourself, do I have a major or minor criteria of a right ventricular involvement? If you don't have, you need to ask, do I have a major criteria of left ventricular involvement? And if it is, then the next step will be genetic assessment to find one specific desmoplastic mutagenic pathogenic gene. And if it is there, this will be enough to establish the diagnosis of LVAC, the left ventricular cardiomyopathy. Now, if you look to the chart, if you have an affection of the right ventricle, you need to ask the second question. Do we have involvement of the left ventricle? And finally, this could be a biventricular disease, and then you need to collect the evidence from the different sources. Accordingly, you can decide this is a definite biventricular, borderline, or possible according to the chart. If you don't, and you have an isolated involvement of the right ventricle, you need to collect the data and decide this is a definite, borderline, or possible. Here is an example of arrhythmogenic left ventricular cardiomyopathy. In this case, we can clearly see the left ventricle demonstrating the classical subendocardial late gadolinium enhancement in the inferior wall of the left ventricle. This alone is considered as a major diagnostic criteria for arrhythmogenic cardiomyopathy. However, you can't rush to establish the diagnosis until you establish a genetic positive diagnosis. So the next step after finding this is to move for genetic assessment. And if the genetic assessment is positive, that is enough to establish the diagnosis of arrhythmogenic left ventricular cardiomyopathy. Here we have another example. Obviously, the arrowheads are pointing to a very strong subepicardial late gadolinium enhancement in the septum of the ventricle. And if you notice of the left ventricle, and if you notice, there is also some degree of left ventricular dilatation. Meanwhile, the right ventricle looks completely normal on MRI basis. Again, this is an example of LVAC, a left ventricular cardiomyopathy. The next step is to establish the genetic association with this case. If you prove the genetic association and there is well-known set of genetic testing, then you can confidently establish the diagnosis. Now, let's go to this case. And if you look carefully to the right, you will notice that you will also see that there is a circumferential transmural enhancement in the wall of the left ventricle. Now, we do have, according to this case, two major criteria coming, one from the right ventricle and one from the left ventricle. Accordingly, you can establish the diagnosis of definite biventricular arrhythmogenic cardiomyopathy. This is in one diagnostic test. Of course, you need to, at this moment, you also need to understand the impact of this on screening of families, because as we know, once you have established this, you probably would invite family members of first degree relatives, especially young people between the age of 20 to 30, to start the screening testing for the possibility of coexistence of the disease. Yeah, here we have this case. And if you see, this is a short axis cross-sectional imaging of the heart. And this is a cross-sectional, and this is a horizontal imaging. You can clearly see that this plastic apical free wall of the right ventricle, this is a dysplastic segment bulging during systole. That's one of the criteria of arrhythmogenic right cardiomyopathy. Meanwhile, you will see some degree of edema in the myocardium, in the septum, and additionally, you can see the very strong subepicardial and transmural late gadolinium enhancement in the septum. This is another example of biventricular arrhythmogenic cardiomyopathy. This is a video, and if we look to this area of the right ventricle apex, you will immediately decide that this area of the apex is actually dyskinetic. It is not moving. It is actually bulging with each contraction of the ventricle. And now if you look to the remainder of the left ventricle, it looks hypokinetic and it has a ventricular dilatation. At this level, you need to be suspicious about biventricular arrhythmogenic cardiomyopathy. There is no actually many diseases that can share in such morphology and such involvement of both ventricles together. The Padua criteria came to solve the problem of the low sensitivity of the task force criteria. And naturally, if you use any modality that would increase the sensitivity, the side effect would be naturally the drop of the specificity. That's why we need to be familiar about the common pitfalls in diagnosing arrhythmogenic cardiomyopathy. This is one of the commonest pitfalls. If you look to the wall of the right ventricle in this case, you may decide that this segment of the right ventricle is actually dyskinetic, but this is actually a normal anatomical variant related to the attachment of the sternum to the pericardial surface of the heart. This is another example. If you look carefully to this area of the right ventricle, you probably will going to say that it is actually poorly contracting. First of all, we don't consider hypokinesia as a criteria of RVAC. And if you carefully start to analyze, you will see it is actually contracting, but it is not contracting as other segment. This is another anatomical variant, and it happens at the attachment of the moderator band. This is another example which we call butterfly apex of the ventricle. This is a normal anatomy, and this is how the ventricle look like. And the key to differentiate this from a case of non-contracting apex is to look to the cine and to monitor the proper contraction of the BCs to differentiate from a case of RVAC. Now we have cases, other causes that might cause ventricular dilatation. This is an exceptional case where you have the superior pulmonary vein draining into the brachiocephalic vein. So it's a case of left to right shunting resulting into right ventricular dilatation. So carefully try to analyze other causes of why you have this ventricular dilatation in your case. Here is a rare case where the coronary sinus actually is unroofed and it is communicating directly with the left atrium. Unroofed coronary sinus is one of the rare forms of also shunting. This is an example also of cases that might cause right ventricular dilatation. And in this case, you can see that the tricuspid valve leaflet is apically migrated toward the apex. So this is an epistine anomaly. Epistine anomaly is another cause of right ventricular dilatation where you should be careful about the differentiation. Another common cause of transmural enhancement is the septal attachment. At the septal attachment of the right ventricle to the left ventricle at these sites, we commonly and normally would have some degree of transmural enhancement of the heart, and this is a natural anatomical phenomena. Now, as we said, transmural enhancement in the left ventricle is one of the criteria of LVAC, which is actually happening in multiple other diseases. This is a case of sarcoidosis, and the most important thing about sarcoidosis that the late gadolinium enhancement is actually happening in a patchy pattern. So if you look to this, you can see patchy nature of the disease. This is unlike LVAC, which happens as a continuous band of late gadolinium enhancement. So we can actually differentiate between sarcoidosis and LVAC. Here we have a patient of myocarditis, and you may claim that this is a subepicardial late gadolinium enhancement. And in fact, in our clinical practice, one of the most important problems that faces us is the differentiation between myocarditis and LVAC. Now, the clinical scenario is fine, but you need to remember, if you have a young patient who is having repeated attacks of unexplained myocarditis, you need to raise the question, this is a true myocarditis or it is an arrhythmogenic left ventricular, for the reason that LVAC is actually presented by hot phases. Hot phases due because of the fibrofatty infiltration can actually destroy the myocytes. And sorry, I'll take 1 minute. Can actually result in destruction of the myocytes and give you exact positive symptom of myocarditis. So the rule here is to insist on follow-up, because we know that recovery is usually full in myocarditis, but there is no recovery in LVAC. LVAC will be persistent. This is an example which is easy differentiated, which is dilated cardiomyopathy. In dilated cardiomyopathy, it is all about dilatation of the left ventricle. But in LVAC, there is no dilatation of the left ventricle until very end of the disease. Easily and quickly, we will go through the pathway of examples of cases, how you manage the cases. This is an example of a case came with arrhythmia pattern. Looking to the MRI, we know that there is a dysplastic area of the right ventricle and the ventricle is dilated. We did an ECG, we did a Holter assessment, and we collected the major and minor. And this was an isolated case of right ventricular involvement, achieving the required number of major and minor, and then you could establish the diagnosis of RVAC. Another example where you have an isolated involvement of the left ventricle with subepicardial enhancement in a patient who is having depolarization, repolarization abnormalities, plus ECG abnormalities, plus family and genetic. Together, you can establish the diagnosis of LVAC. And finally, this is a case where you have another case where you see a late subepicardial enhancement, and this is a case of also arrhythmogenic left ventricular. By that, I ask you to share the PowerPoint at the end of the conference, and please feel free to communicate with us to explain further about the procedures and the techniques for Padua criteria for arrhythmogenic cardiomyopathy. Thank you.
Thank you, Dr. Ahmed, and always your presence adds value to our cardiology. Please. And now I will introduce our next speaker, Dr. Walid Azdat, consultant cardiology, Imperial College. His subject, a case of non-compaction cardiomyopathy. Welcome, Dr. Walid.
So good evening, everyone. I will be quick. I'd like to thank Dr. Ahmed for being with us tonight, and I believe it's a very good opportunity because we'll use our input on this case. So I'll call it a non-compaction, not cardiomyopathy, non-compaction only, because it might be without cardiomyopathy, or it will happen later on. So we have a case here, a 46 years old male, type 2 diabetic patient, a CKD phlebotomic range, hypertensive, referred actually 3 years ago for non-specific chest pain, and ECG echo were done for that. The ECG, any participation, any abnormality? Dr. Joseph? Nothing specific, I believe. Conduction is fine. The QRS complex does not have any BEFID or whatever. So let's move on. This is the echo. What about the ejection fraction? Is it normal? Yeah, I believe it fairly touches the 50. It's not a 55%. What about the apex? Do we find anything strange?
Sort of non-compaction there.
Forget about the title. Maybe it's wrong. There's some recesses, but we are not sure actually at this time. So this was the echo done in 2024 when I saw the patient, but I couldn't grab the images from 2022. But the 2022 was suspicious. That's why they gave the patient a cardiac MRI for the ejection fraction of 50% for ejection fraction. So at this time, we know that the MRI is a gold standard in EF assessment and also delineation of the left ventricle. And this was the your right side, the cardiac MRI short axis at 2022, and this is the 2024 follow-up MRI. So any difference between both? So what about ejection fraction? Is it the same? Any input? So is it getting better or getting worse or static? Let's take another view.
It seems worse.
I believe the ejection fraction in the 2024 is getting worse, getting less. Maybe not that much poor LV function, but it's in the mild reduced range, and it was in the third ejection fraction range. So I believe here is 45 by polling, and the 2022 was actually almost 50% ejection fraction. Another view. Another view. We can see some recesses also, more prominent 2024. So this is the MRI 2022. We can see the ejection fraction is fair, only 50%, and we have mild hypokinesis overall. And there was no GAD enhancement. There is no retention of the contrast at that time. And there was an uncompacted area, like you have seen in the apical part, and the actual calculation was less than 2.3. That's why they sought a suspicious of LV non-compaction, not fulfilling the criteria. That's why a follow-up annually was recommended. So this is the MRI afterwards, which we saw. Ejection fraction was dropped to 45%, and we have more than 4 segments involved, and actually the ratio was more than 2.3, as we will discuss later, the criteria of diagnosis. And the subendocardial delayed enhancement actually was evident in the follow-up 2024 study. So what is the LV non-compaction? It is actually a deep ejaculation or recesses inside the myocardium, which can lead to a cardiomyopathy, heart failure, or even arrhythmias. And at certain points, it can do a thromboembolic manifestations. This is the typical LV non-compaction, but unfortunately, we only see this on autopsies. So we cannot do this in live patients, but it gives us the shape of spongiform or non-compacted recesses, which is the pathology and the LV non-compaction. So it started almost very early in the 75 by Duke, who first prescribed it by the 2D modality at 84. And after a decade or 3 decades, actually, it came a little bit more applicable with MRI, but there was no definite genetic testing at this time for the disease. So if we wanted to a little bit go through the embryology, how this actually happened, through the embryonic life, before formation of the coronary arteries, the myocardium actually started as a meshwork of a little bit less density meshwork, which with time tries to condense more and more to give you a compacted myocardium. At a certain point, this process might be arrested. And another theory also that it develops in 2 forms, one non-compacted segments and one compacted segments, but the progress of the compacted segment is arrested. That's why the non-compacted prevails. And the similar phenotypes of the non-compacted, the LV non-compaction, may be dilated cardiomyopathy and HCM, restrictive cardiomyopathy, and the left dominant arrhythmogenic cardiomyopathy, as actually well discussed by Dr. Ahmed. And one of the even MRIs he has showed, I could see some recesses in the other LV myocardium. We may review the images later with him, but it's actually maybe related to other RV pathologies as well. And we have other associations like metabolic syndrome, genetic syndromes, and we have the children and elderly, and the more prevalence in infants. Actually, we're talking about 0.9% per 100,000 patients, and in the children it goes down to 0.1 to each 100,000 patients. It's a little bit rare disease, so if we combine it to left and right LV non-compaction, it will be more rare and more than women affected by this. So if we go to the presentation of the LV non-compaction, we can have an heart failure, symptoms like dyspnea, chest pain, arrhythmia like atrial fibrillation or ventricular tachycardia, or thromboembolism like the CVA-TIA or pulmonary embolism. And the electrophysiology, we might have like our patient normal ECG, or we might have a wide complex, QRS complex for the conduction delay, left or right axis deviation, PR prolongation, or even other arrhythmias, or a sinus bradycardia, or even WBW in some cases. So what about the thromboembolism, stroke, TIA, and pulmonary embolism, and reported actually reaching up to less than 40%. And the etiology is actually stasis of blood in the deep recesses. So the deeper recess, the more probability you have a thromboembolism with the deep invagination, and the more stasis of blood, and the even more if you have a concomitant atrial fibrillation. So so what about the gold standard technique to diagnose the LV non-compaction? Actually, we don't have a gold standard. We have a combination of modalities. It's a multimodality assessment and confirmed by genetic testing. So the most common used criteria is echo-based and MRI-based. Starting with the echo-based, Chen et al. Is one of the good studies conducted, and Jenny et al. And Stolberg et al. Is the one also with the echo finding. So starting with the Chen, it measures the non-compacted to the compacted area, so which should be below 0.5 positivity. And the Jenny et al., it gives you a two-layer myocardium, one compacted, one non-compacted. If the ratio is above 2, this is actually a diagnosis. And this Stolberg gives you have to have more than 3 trabeculae with one only imaging plane, and along with this perfuse the intertrabecular space by color Doppler to make sure it's a true recess. But if we look here about the timing we use, to measure the thickness, and the Chen et al. Gives you in the end diastole, and the Jenny et al. Gives you to measure in the end systole. And here actually it depends on the for a chamber view, and it's not related because it measures actually the deep invagination of the recess itself. What about the MRI? This is the most common criteria used. If you have a 2-layered myocardium, the non-compaction to compaction ratio is above 2.3, measured at end diastole, and the Jacquire et al. Study giving you that you might have an LV mass index of the trabeculated more than 20% of the total LV mass. This gives you a diagnosis of LV non-compaction and measured at the end diastole. So now, do we use the end systole or end diastole? As per the ASC and ASE guideline, dimensions of the myocardium is better to be measured in the end diastole. But actually, this is a special situation of the disease where the end systole also can give you a difference, because sometimes the non-compacted myocardium is not compacted or even giving you a good systolic thickness, and the compacted myocardium may give you a more extent of the thickness. That's why measuring in this phase might even give you a difference in management and even assessment. So going to the first diagnostic criteria, we told about X and Y. This is the Chen et al. The same. The X actually is the area of the compaction, and the Y is the area of the non-compaction. If you divide it both, and if you have 0.5 or below, you have a diagnosis in the end diastole. And if we go to the Jenny, it actually gives you a diagnosis in the end systole of more than double the non-compacted to compacted ratio. And if we go to the validation of the Jenny criteria, we have a publication, and at the end of it, it said that although we have non-compaction criteria occasionally found in other heart disease like the ARVC or even dilated cardiomyopathy, the combination of all the criteria along with genetic testing is essential to elaborate a diagnosis. The cardiac MRI is a very good tool to use it with, and as we have discussed in the Jacquire et al., you need to have a 2.3 non-compacted to compacted ratio to obtain a diagnosis, or even you have above 20% LV trabecular mass index more than 20 to establish a diagnosis. And I believe Dr. Amado can correct me, it needs a special software in the MRI to give you a good LV mass accurately. So what about the management? What about the management and follow-up? These are, we don't have much data about the follow-up of these cases, but we have an abstract of 34 adults who had LV non-compaction, and we can see that 53% of them had heart failure symptoms, deaths from heart failure, sudden cardiac death, heart transplantation, and syncope, almost ranging from 2 to 12 patients from this group. And about the symptom signs, the NIHA classification, syncope, and also from the ventricular arrhythmias or even transient ischemic attack and thromboembolic manifestation, including pulmonary embolism. So how we manage these? Actually, we manage this as a cardiomyopathy case. We have a heart failure, we treat heart failure. We had atrial fibrillation or thromboembolic complication. We treat it as it is, and we should actually add on a screening of the families. If we have an SC arrhythmia, we consider an ICD. Genetics used, all of these can be used as genetic testing for this case to elaborate a diagnosis along with the imaging criteria. So back to our case, 46 years old male, type 2 diabetes, CKD, proteinuria, hypertensive, and the presentation here, this is MRI, and these are the parameters. And actually, I want to thank Dr. Ahmed Sharif, the radiologist from Cleveland Clinic, because this is his measurements. We can see here the increase of the non-compacted area over time. Here was 19, and I believe here was over 23. If we move forward, another view, it gives us also more increase in the non-compacted segment and the decrease in the compacted segment. And this is the summation of all the segments and all the 3 recesses found. We can see that the non-compacted area is getting thicker and the compacted area is getting narrower. And what is more important here, that the late gadolinium enhancement is more evident in the follow-up study after 2 years, and ejection fraction is impaired from 50 to 45%. And that's the cause we have went to the diagnosis of non-compaction cardiomyopathy for this case. So Holter and ECG for this patient were normal, and we did genetic testing for him, MYH7 and NT2 genetics, which were negative, and he had no family history. So we have 2 algorithms to diagnose the LV non-compaction. If we go to this algorithm, the initial criteria of family history is not present. Medical history, actually the patient is asymptomatic currently. Imaging modality, we have LV ejection fraction below 50%, yes. We have actually impairment in the GLS, yes. Diastolic dysfunction, yes. And if we go here, the patient having one of the above or more, and nothing else explaining the LV non-compaction, so the diagnosis should be non-compaction cardiomyopathy. Another algorithm from the literature, modified Rotterdam criteria, depending mostly on the symptoms. So if we have a patient asymptomatic like our case, and at the same time negative family history, negative genetic testing, and the negative normal ECG, and the morphologically features of non-HCM, non-compacted cardiomyopathy, and this time you can call it a non-compacted cardiomyopathy trait, so it's not a diagnosis. With all of this, I believe we are still in doubt, was it the tool to use, because we have 2 different algorithms. One is positive and one giving us to rule out, and the management as per the guidelines. I'm 1 minute only. So the guidelines even not giving us a clear guideline, because it's a based approach on the case, presentation, and complication appear along with genetic testing and the family history. And by this, we go to the conclusions. It's rare congenital heart disease. We need a multimodality approach, and we are dealing with the complication as heart failure, arrhythmia, thromboembolism, diagnosis by echocardiography. It may be considered, CMRI should be considered even to add a value to the management. Late GAD enhancement can add a rule, variable prognosis, and treatment based on the clinical manifestation. And thank you very much.
Thank you, Dr. Walid, for this elegant presentation. And now I will introduce our next speaker, Dr. Fadi Gerges, cardiologist, Mediclinic. The added value, postpone tomorrow. Next speaker will be Dr. Hani Sabur for Pfizer Symposium. Okay, Dr. Hani. Thank you for you. I'll keep the floor for Dr. Hani to do his presentation.
going to think the only disease we have to talk about today is also ATTR cardiomyopathy. So this is a second talk about this, and I think it also highlights the importance of outcome-based therapies in cardiomyopathy. So actually, I'm going to talk today about the other treatment of cardiomyopathy, and that is the use of tafamidis. Tafamidis, as you know, is a silencer. It's not a silencer, it's a stabilizer. And it's indicated for the following. It's the treatment of adults with ATTR cardiomyopathy, wild or hereditary. And the indication highlighted in yellow is to reduce cardiovascular mortality and cardiovascular related complications. Just to tell you that the treatment of this disease does impact life-saving medication. So what is ATTR cardiomyopathy? We talked about it briefly in the first session. It is a production, abnormal production of this amyloid fiber. This comes from the common PPR. Transthyretin is the binder of thyroid hormone, so it's everybody has it. However, there is abnormality in the formation that causes this fiber to form. This fiber deposits in the heart as well as the nerves and in some cases the kidney. It looks like a nylon fiber. So imagine your heart and your nerve endings surrounded by nylon, and this is why it's going to be a very toxic situation. So how common? Actually, it's much more common than you think. So in patients with left ventricular hypertrophy, 13%. Patients undergoing aortic valve replacement, 16%. And in patients with HFpEF over 50 years, 17%. So seeing patients with hypertrophy, with aortic stenosis, with HFpEF, please do not ignore this diagnosis and please get the correct test. So in patients with hypertrophic cardiomyopathy, and I think Dr. Walid did a beautiful presentation on a patient with non-compaction, hypertrophic cardiomyopathy, 50 years old with a thickness more than 15, 1 in 5 had ATTR cardiomyopathy. So it isn't just HOCM. Don't think of HOCM alone. Always think of the presence of a phenocopy, especially if the ventricle is very thick. The addition component is severe heart failure, carpal tunnel syndrome, and male sex, 1 in 5. So there are a lot of situations where people will give another diagnosis and forget to think about cardiac amyloid. So we're going to go from suspicion to actual diagnosis. Is it easy to make a diagnosis of ATTR? Yes, if you think about it. No, if you don't think about it, right? So you have an 84-year-old patient who has a history of hypertension, hyperlipidemia, bilateral carpal tunnel syndrome. Remember I told you this is the real flu. Had a left hip replacement, had another surgery for carpal tunnel again. So recurrent carpal tunnel syndrome is another big clue here. And dyspnea with exercise, acute heart failure, ejection fraction 45%, and was given the conventional therapy, beta blocker, ACE, SGLT2, MRA. And with beta blockers, we had worsening of heart failure, syncope and bradycardia, and the patient needed a pacemaker. So what are the red flags in this patient? Okay, 2 times carpal tunnel syndrome surgery, also worsening with heart failure therapy. So this is what we call intolerant. And also the need for conduction system relief, i.e. progressive left bundle branch block. It's telling you that there's an infiltrative process going on. NT-proBNP very high, 2,800, and a constantly elevated troponin, in spite of the fact that the coronaries don't have significant disease, normal kidney function. Now, when you do this evaluation, you should always do an evaluation for looking at paraproteins. The presence of free light chains, serum or urine, are also a clue that there could be another type. In elderly patients, you can have MGUS or you can have a AL type. So what are the signs here? Acute and chronic heart failure, intolerance to beta blockers, very high NT-proBNP and a troponin in a patient who's not volume overloaded, and carpal tunnel syndrome, bilateral surgery multiple times, or sensory neural hearing loss is another one of the findings. So the red flags, as we mentioned, in a patient with heart failure. Hypotension, if patient hypertensive in the past. Low voltage, AV conduction disease, the patient had a bundle branch block, needed a pacemaker. Very high BNP and troponin without significant coronary disease. And on the echo, thickening of the right ventricle, left ventricle, interatrial septum, apical sparing with longitudinal strain. And on the cardiac MRI, increased extracellular volume and native T1. If you ask for a cardiac MRI, you have to tell your MRI radiologist, I'm looking for cardiac amyloid, because it's a special protocol and a special series that you won't get on a standard MRI. And I have several patients where the MRI was not specifically requested like this, and the answer came back sarcoidosis or myocarditis, right? So you need to inform the MRI physician that I'm specifically looking for amyloid so they can set up the protocol for that. And I'll ask Dr. Ahmad a question about this. So, HFpEF, especially aortic stenosis and arrhythmias. Elevated troponin disproportionate, low LV volume, low LV, increased LV thickness with low voltage, orthopedic conditions, thick ventricle, and neurological symptoms, including GI. Look at this echo. Do you have any doubts about this one? Thick ventricle, increased speckling, biatrial enlargement, pericardial effusion, thick interatrial septum. This is textbook, right? How many echoes did this patient have before somebody thought of cardiac amyloidosis? 8. Everybody said LVH due to hypertension, but the patient's not hypertensive. Getting worse with hypertensive medication, right? And when you do the apical sparing, the technician takes 1 extra minute to acquire this. Look at that, reduced global strain, it's -7, -3, except at the apex. So everything is down except the apex. The port flume and thick ventricle is obvious. So when you use the echo, thick ventricle, you have significant diastolic dysfunction and biatrial enlargement, apical sparing, and a small A wave and sinus rhythm. These are just clues. Remember to think about these clues before the patient leaves the clinic. Now, when you look at cardiac MRI, and of course I'm not the expert, Dr. Ahmad here is the expert in cardiac MRI. These are simple things that you have to look at. Difficulty in achieving myocardial nulling, diffuse late enhancement, very high extracellular volume. That's the position of the protein and the fibrils between the myocytes, and high T1 mapping. And of course, you have the other morphological features. But you have to ask the MRI team, I'm looking for amyloid, so that they do the T1 mapping and they do the special recovery sequences. The bottom line is this. This is the test that makes the diagnosis. It's quite simple. You are doing a bone scan. It's simply a bone scan. It's exactly the same medicine used for a bone scan. You see the heart has more uptake than the spine or the ribs. Very abnormal. That means there is bone in the heart. It's not really bone, it's just the myocardial perfusion. And you see it in the 3D images. It's very clear, and the score is very high. The other important thing is to exclude AL. So elderly patients can have MGUS, monoclonal gammopathy with unknown significance, or they can have AL amyloid. Very simple. You're going to look for serum free light chain, serum and urine immunofixation. Okay? Any abnormality here, this could well be AL amyloid. If it's negative, this patient has TTR. You don't have to go through a long differential diagnosis. Now, the different radiotracers are positive, but clearly if you have something like this or this patient has similar uptake to bone, and therefore this is very abnormal, and you can start treating right away. You need to do genetic testing. Genetic testing, we don't know if we have the right genetic testing in the Middle East. We are not aware of every single genotype that can be given in these patients. So if it's positive, it's great. If it's negative, it does not exclude the disease. This is a very important differentiation. So here's your 84-year-old with what? Heart failure, carpal tunnel syndrome, hip replacement, deafness, needed a pacemaker, severe functional class 3, beta blocker intolerance, thick ventricle, apical sparing, BNP tropomonitis, needs a pacemaker implant, strongly positive cardiac scintigraphy, and no evidence of paraproteinemia. Genetic testing done or not done, wild type CM. So the algorithm works like this. And in the algorithm, and this does not apply in the UAE, it says, is it available or possible? That's wrong. As I mentioned, there's 4 hospitals that have nuclear scanning with the highest level of precision. So you shouldn't do this. You should go directly or refer to your colleagues who have the nuclear scan. And if it's abnormal, you have the diagnosis, keep going. So why do we care? Because we have treatments that impact survival. As I mentioned, the indication for tafamidis is to reduce mortality in these patients. So can we treat it? Yes, we can. The treatment is this. Stabilizers like this prevent this from dissociating into this nylon fiber that poisons the heart. This is the only treatment that specifically targets TTR stabilization. So this is the clinical study. It's called the ATTRACT study. And they had a large number of patients, elderly patients, males more than females, as you expect, genetic and wild type, and severe functional class is there in the patients as well. What is about survival? All-cause mortality and CV hospitalization significantly reduced, and those patients within 30 months had significantly less hospitalization. So it is clearly impacting with over 30 months. And this is the pooled group of patients, reduced mortality by 30%, number needed to treat 7.5 within the 30-month period. So this is definitely in the same category of mortality reduction as sacubitril valsartan. When you look at the heart failure hospitalizations, only 4 number needed to treat to reduce hospitalization by 30% over 3 months. So it's highly impactful in terms of patient survival and quality of life, significantly improved. You do a 6-minute walk, it's significantly better. You see the same kind of effect in patients with heart failure and reduced ejection fraction as well. What about long-term data? So now the data has been opened to an open label study that continues for a long period of time. And you see the difference in the placebo arm. 4,500 is the NT-proBNP, significantly different. And what happens at month 72? They continue to have lesser mortality and 5-year all-cause mortality, 41%, much better survival with the medication compared to placebo. So, what patients can you use? Are there any patients that have a specific benefit over the others? So, if you looked at patients with severe heart failure, functional class 3, even severe heart failure, significant improvement, but 64% hazard ratio, i.e. 36% improvement. But those patients with early stages, functional class 1 and 2, 50% reduction of mortality. So the earlier you diagnose and earlier you refer, the better we can have an outcome. What about elderly patients? This is a disease of the elderly. So sometimes physicians will say, well, the patient's too old, just leave them alone. This is the study looking at more than 80 versus less than 80. Octogenarians over 80 years old had a longer median survival and a lower mortality, even if they were over 80 or less than 80. So there is no person too old to get this therapy to save their life. And also, remarkably, in the older patients, they were able to walk longer. Imagine that they're getting a 30 to 40 meter increased 6-minute walk distance that improves their quality of life and gets them out of the hospital. So overall, the long-term mortality reduction with this therapy is 41% in all comers, right? And we saw similar data when you used in heart failure with beta blockers and ACE inhibitors and ARBs, but you cannot use ACEs and ARBs in these patients. They actually make them a lot worse. So what about ejection fraction? What's the impact of ejection fraction in these patients? So when we looked at these patients with ejection fraction less than 50% or ejection fraction more than 50%, what did we see? So the lower ejection fraction patients had a significant benefit, and the normal ejection fractions also had a significant benefit. And this is almost at 72 months. So this is a 33% reduction, and this is a 33% reduction. So ejection fraction is irrelevant. If you are on this medication, it will improve your survival. This is looking at mortality with ejection fraction. And this is the hazard ratio over the long term in these patients. The KCCQ, which is a quality of life questionnaire, is significantly better compared to both groups with the ejection fraction being higher. So what about adverse events? Obviously, we're all concerned about having patients who are elderly. Adverse events compared to placebo are almost exactly the same. There's no new safety event, almost the same as placebo over 58 months. So older patients, younger patients, low and normal ejection fraction, no safety differences. Now, this is also real-world data. Again, some of us don't participate in randomized clinical studies. You want to see how this works in your own patients. So it's 1,400 patients in this registry, and of those patients, the tafamidis treated were the predominant phenotype. So it's an observational study, but what do you see here? The survival rates at 30 months and 42 months in patients receiving tafamidis in the real world, open label, of course, is significantly different. 81% here, 59% here. And again, in these patients after 2020, the later cohort, so this is at any time, and this is after the later enrollment, after the COVID as well, significant difference. So the survival, and this is overall survival, death from any cause, is significantly different in real-world studies of patients receiving tafamidis in this group. Again, in this open-label study, which is real-world, there was no difference of adverse events compared to the others. So what's the key observation? The 30-month survival in the analysis was higher for tafamidis, and in these patients compared with any year of tafamidis, they had a significant outcome. Safety and tolerability was great and reinforces the need for early diagnosis and treatment and continue to support the effectiveness of the tafamidis. So, summary, we have data from randomized studies, long-term studies, as well as open-label, non-randomized real-world studies, showing a significant reduction in mortality, improvement in functional class, and in addition, compared to placebo, a significant reduction of all-cause mortality in a heart failure disease that you cannot use ACE, ARB, ARNI, or Entresto. The post-hoc analysis in older patients, significant median survival and lower mortality, and lower decline in 6-minute walk, as well as reduction in heart failure hospitalization. And also in real-world cohorts, yours and my patients increased survival rates treated compared to patients who are untreated. So, thank you very much. I hope this has been a reason for us to consider early diagnosis, early referral, and also initiating treatment as soon as possible in these patients.